GI pathology, other intestinal disorders. All right, so let's start with acute mesenteric ischemia. Acute mesenteric ischemia is just blockage of intestinal blood flow, okay? So it's usually embolic occlusion of the SMA, and it can lead to small bowel necrosis. Now, the patient's going to present with abdominal pain out of proportion to physical exam, okay? You can see red currant jelly stools, and risk factors include anything that can lead to an embolus in the SMA, like atrial fibrillation, and then you could also have like recent MI or CHF. Angiodysplasia is going to be tortuous dilations of the vessels leading to hematochezia, lower GI bleed, and it's most often found in the right-sided colon, okay? It's going to be seen most commonly in older patients, all right? Next is chronic mesenteric ischemia. Of the ones I've listed so far, this is probably the highest yield one. This is going to be intestinal angina. So you know how we have angina involving the heart? When we don't have enough blood supply, it causes referred pain. This is the same thing, but it's instead of the heart vessels, it's the intestinal vessels. So we have atherosclerosis of the celiac artery, most commonly the SMA or the IMA, okay? So SMA is the most commonly affected by atherosclerosis, leading to intestinal angina. And what happens is that whenever you eat, right after you eat, you have postprandial epigastric pain. And so you get food aversion and weight loss. It makes logical sense though. The reason it's postprandial is because whenever a patient eats, it's going to lead to increased blood flow towards that area. And increased blood flow, specifically via the SMA, with an atherosclerotic blockage, is going to cause pain because there's not enough blood flow present. Okay, so that's known as intestinal angina or chronic mesenteric ischemia. Okay. And honestly, I think the way that they presented it was like they said that the patient had severe pain right after eating and they have food aversion and weight loss because of it. And they have like history of atherosclerosis. And they say, this patient's pathology is most similar to which of the following pathologies? And the answer was like angina for the heart, okay? Because this is known as intestinal angina, all right? Next is ileus. Ileus is just intestinal hypomotility. There's no obstruction though. And it's usually just like it leads to constipation and decrease in like flatulence, decrease in farting, okay? Flatus. And usually associated with like any type of surgery or opiates, okay? It can cause ileus. Next is necrotizing enterocolitis. Whenever you see a preemie, okay, so a premature baby that's formula fed, okay, and now they have air within the bowel wall, this is known as pneumatosis intestinalis, think necrotizing enterocolitis. So it's a premature baby that's now formula fed, and now they're having all these GI issues, and they do a GI X-ray, and they see abdominal X-ray, and they see pneumatosis intestinalis, which is just air in the bowel wall. Then it's necrotizing enterocolitis. Okay, so for me, whenever I saw a premature baby that was being fed formula, that was like the first thing on my differential, necrotizing enterocolitis. Okay. Next is small bowel obstruction. Small bowel obstructions usually is inability to pass gas or stool, right? So it's interrupted flow of normal physiological flow of the small bowel. And what they want you to know is that patients are usually caused by three things, the A, B's, and C's of our small bowel obstruction. A being adhesions, so previous surgery. When you close up a previous surgical wound, there can be adhesions, which is the healing process of the body, that could then potentially cause a small bowel obstruction. The B's is bulge meaning hernia. So if you have a hernia, that can cause a small bowel obstruction. And then C is cancer. Any cancer can lead to a small bowel obstruction. All right, on upright abdominal chest X-ray, if you see air fluid levels, take a look at what that looks like on chest X-ray, on abdominal X-ray. Very high yield to know. Air fluid levels are highly associated with small bowel obstruction. Remember your A, B's, and C's, okay? Now, last thing is SIBO, which is small intestinal bacterial overgrowth. What usually happens here is that you have abnormal bacterial overgrowth in the small intestine, right? Now, it causes chronic watery diarrhea. So if you see chronic watery diarrhea, start thinking SIBO as one of your differentials. And what happens is it usually is associated with like anatomical abnormalities. So if like a patient had like a bypass surgery or small bowel obstruction or something associated that way, or they have dysmotility from gastroparesis, right? Anything like that can lead to it. It could be seen in scleroderma as well, which we'll talk about in room. So it can be due to also impaired MMC function, right? We talked about motilin causing MMC production and function. And so it usually is due to the inability for motilin to like keep peristalsis flowing. So when you don't have peristalsis flowing, then you have just buildup of that bacteria, and it leads to that chronic watery diarrhea seen, right? Now, the way that you treat this is giving the patient oral antibiotics because you want to just kill off some of that overgrowth of the bacteria. So that's pretty much the other intestinal disorders. Not too high yield. I would focus on small bowel obstruction, small intestinal bacterial overgrowth, SIBO, necrotizing enterocolitis, and then maybe chronic mesenteric ischemia, although it's low yield. All the other ones are relatively very, very low yield, okay?